Good afternoon, all. Welcome to yet another session of Transfusion Medicine Academic Society. Today's session is on calculations in transfusion medicine, which I am sure will be useful for both PGs and consultants alike. Before starting the session, there is an announcement. The certificate link will be shared in the chat box. Kindly fill the form so that the certificate will be sent to your mail ID. Let me now introduce the speaker of the day, Dr. Mohandoss Murugesan. Sir has done MD in Transfusion Medicine from JIPMER, now working as Additional Professor in Transfusion Medicine at Malabar Cancer Centre, Talasheri, Kerala. His areas of interest are apheresis and flow cytometry. Sir has won ISTM Young Scientist Award in 2019. We are happy to have you here. Now over to you, sir.
Very good afternoon, all. I would like to thank the Scientific Committee of Transfusion Medicine Academic Society for inviting for this lecture. So I'll directly move on to my lecture. So I would like to keep this presentation as simple as possible. So I have reviewed few exam questionnaires which were asked commonly, and I'm trying to answer those questionnaires through this presentation. So any complex calculations which require, so please put in your chat box. We can have a personal discussion in the later times. The common question asked is estimating the blood requirements of a tertiary care hospital. So in this case, it is a 1,000-bedded unit. So there are multiple tools to estimate the blood needs of a center. So the first commonly used one is geography. So that used to help the estimating the blood requirements for a country. So like the example, the 2% of the country's population is the requirement of blood transfusion annually. So the next formula used is bed strength. So this is what we are going to discuss in the next few slides. And the third formula is predictions based on the past utilization. This is also commonly used formula, which can be done used on a real-time basis. And the last one is blood needs as per diagnosis. In this case, the age and the gender of patients, the clinical conditions requiring highest number of transfusions, and number of patients that receive transfusions are estimated over a period of 1 year or certain time points. So then they used to predict a number of units required for a hospital. So among the four concepts, the concept number 4 appears to be relatively scientific, and but it's not practiced much. From an exam point of view, so we use the formula based on bed strength. So in the bed strength, so any hospital on an average, they have 10% of their inpatient beds as an acute beds, that is emergency beds or intensive care beds. So, and the rest of the beds can be standard beds. So the blood requirements is for acute beds, we need minimum of 20 units annually. And for standard beds or normal beds, we require minimum of 7 units annually. So in this case, for acute beds, it comes around 2000 units. And for standard or normal beds, it comes around 6300 units. So approximately, when we estimate a blood transfusion requirement, it comes around 8300 units based on the bed strength. So we can also use a prediction based on the past utilization and improvise our blood estimation. For example, in a center which has a in the current year, the blood requirement was 10,000. So we can use the prediction to estimate the future requirements. For example, in this case, it is the utilization in the previous year plus 10% for the discard, then 5% for the disaster, anticipating disaster, and 10% increasing demand. And if the center increases bed strength, that has to be considered. So by going by this, we can estimate the formula as like 10,000 is the current year's requirement. 10% of the 10,000 is for discarding, that is 12,000. And for disaster, it is 5%, that is 500. And for increasing demand, that is 1,000. So it roughly comes around 12,500. So these are the methods which we can estimate the blood transfusion for a center. So coming to the next topic, antibody titer. I just briefly review about the antibody titer. So it's a case, a 23-year-old pregnant woman is being followed because she has multiple antibodies. So she has a complex antibody like anti-capital K, anti-Duffy A, and anti-JKB. And the father is known to be positive for FIA antigen. So maybe the other exposures are maybe through blood transfusion or some other means. So her previous, and she was a known case of ICT positive. Her antibody titer in the previous sample was 32, and they have labeled the score as 38. So now the patient has visited our center. So we need to determine the level of monitoring that is required for the needed for the adverse effect on the fetus. So the present titer is the picture shown here. So the titer is the highest dilution which gives a 1+ reaction. So in this case, the titer is 64 dilutions. And so we are asked to, so we have a 1-fold increase in dilutions. So then we have to proceed for the strength of the reaction based on a score. So we all are aware about the scoring system. If agglutination is 4+, we use a score of 12. If the agglutination is 3+, 10. If the agglutination is 2+, we use a score 8. And if the agglutination is 1, we use a score 5. So in this case, the score is around 48 based on the antibody titration. So the titer has 1-fold increase in dilution, whereas the score has a more of 10 from the previous values. The previous value is 36. So in this case, we consider when we consider the titer is significant is when there's a change in 2 dilutions or a change in score of more of 10. So in this case, it is considered significant, and we have to manage the pregnancy affecting the taking care of the fetal requirements. With respect to the same patient, so if a patient is planned for the intrauterine transfusion and the estimated fetal weight of the is 1800 grams by ultrasonography, and the fetal hematocrit is 28% by the cardiocentesis. So the preferred bag hematocrit from the clinician was 70 to 85%, and the bag which we chose was 88% hematocrit. So determine the volume of transfusion for intrauterine purpose. So to determine that, first we need to estimate the fetoplacental volume. The fetoplacental volume is estimated as fetal weight into 0.14. Once we estimate the fetoplacental volume, the volume to be transfused for intrauterine transfusion is fetoplacental volume into desired hematocrit minus actual hematocrit by the hematocrit of the bag. So in this case, the fetoplacental volume is coming around 252 ml, and the desired hematocrit for intrauterine transfusions are usually 45%, and the hematocrit of this baby like fetus is 28%, and the bag which we chose the hematocrit of 88%. So the volume turns around to be 48.6 ml. So like maybe around 50 ml is the volume required for intrauterine transfusions. So this is the formula based method to estimate the intrauterine transfusion. Few centers use graph. The graph is referred as Mary's graph. Here, for example, if the fetus is around 32 weeks of gestation, so if you can trace the graph, the curve, so you can estimate the fetoplacental blood volume, so which is around 140 ml used on the graph which is pictured on the left side. So the fetoplacental volume is 140 ml in this case, and the fetal hemoglobin was around 9.3 grams, and the hematocrit turns around to be 28%. So the fetal hematocrit on the second picture is on the x-axis, and it is 28%, and the bag hematocrits on the y-axis. So we have the bag around 88%. So we need to intersect these 2 points. While intersecting, we are crossing a point of 0.3 here. So we need to multiply the fetoplacental volume into 0.3. That comes around 45 ml. So this is also a method to estimate intrauterine transfusions. The same like that for a discussion sake, the same mother at 38 weeks of gestation, so we know she has a complex antibody of anti-capital K, anti-Duffy A, anti-JKB. Her weight is 60 kilograms. So post-delivery, her fetal screen test, that is Rosette test, which is a qualitative test, was performed, and the result was positive. So the question is to estimate a fetal-maternal hemorrhage, and we are asked to do a Kleihar-Betke test. So the bottom picture you can see the Kleihar-Betke test. The prominent ones are the fetal RBCs, and the background we can identify the maternal RBCs. So to estimate fetal-maternal hemorrhage, first we need to understand the maternal red cell volume. So red cell volume in an average maternal case is 1800 ml. So this is estimated by maternal total blood volume into hematocrit. That is 1800 ml for a calculation purpose. And overall, the fetal cells are 22% larger than the maternal cells. And by Kleihar-Betke test, that is acid elution method, only 92% of the fetal cells darkly stained. So using this, the fetal maternal hemorrhage can be calculated as number of fetal cells per high power field by number of maternal cells in high power field into 1800. That is the maternal red cell volume into 122 by 100. That is the fetal cells are 22% larger than the maternal cells. So it is 122, and the percentage of fetal cells are 92% stained darkly. So it is 92 by 100. Its denominator is 92 by 100. So when we take it to the numerator, it is 100 by 92. In simple terms, it can be classified mentioned as number of fetal cells per high power field by maternal cells into 2400. So the assay was done. So the number of fetal cells was observed to be 25 fetal cells per 2000 cells counted. That is the maternal cells. So the volume can be estimated as 25 divided by maternal cells, that is 2000, into the factor, a constant factor, that is 2400. It works out to be 30 ml of fetal-maternal hemorrhage has happened in this mother. So the further reading, you can refer the guideline from BCFH 2009. So we can also estimate the fetal-maternal hemorrhage by flow cytometer. In flow cytometer, it is percentage of fetal cells into 1800 into the fetal cell volume, that is 122 by 100. The staining will not be a factor involved in flow cytometer. So it can be simplified as percentage of fetal cells into 18 into 1.22. There are other methods to estimate fetal-maternal hemorrhage. This is one of the method. So where we use a maternal total blood volume into fetal cell counts by total cell counted. Using this formula, so we could estimate as if the mother is 60 kg, so the blood volume is estimated as 4200 ml, and an average adult has 70 ml per kilogram body weight. So it is 60 into 70 into 25 cells, that is the fetal cells counted by the total cells counted is 2000. It comes around 52.5 ml. So this method slightly overestimates the fetal hemorrhage when compared to the previous method described in the guidelines, BCHS guidelines. So to calculate the number of RH immunoglobulin vials required, so the fetal hemorrhage by 30. The 30 represents one vial can neutralize up to 30 ml of the blood, whole blood as such. So in this case, the fetal-maternal hemorrhage was 30 ml. So we need only one vial, so 30 divided by 30, which gives you a value of 1. So for immunoglobulin administration, so we always add 1 to the values which we obtain. So that is 2. So if there is if the values comes in decimals, for example, the values 1.5 are or 0.5 or above, so we need to round the decimal to the next possible digit. In this case, 1.5 can be represented as 2 plus 1. That is 3 vials are required for this patient. If the values are the decimal of less than 0.4, for example 1.4, so we have to round to the previous actual digit, that is 1, and add 1 to it. So that is 2 vials will be required for immunoglobulin administration. This is with respect to the fetal-maternal hemorrhage as well as immunoglobulin administration. So coming to the compatible units for this patient, the patient was the fetal newborn was planned a double volume exchange transfusion. So we are asked for randomly screening the type O RBC units which are negative for capital K, Duffy A, and JKB antigens. So how many units would be needed to screen to find 2 antigen negative units? and the antigen negative frequencies are given. So capital K negative frequency are 90%, WA negative frequency is 35%, and KIT B negative frequency is 30%. So the general practice is to transfuse patients with alloantibodies which are antigen negative. The formula for estimating the number of units to be screened are number of units desired. So in this case it is 2, and multiply divide by antigen negative frequency. So we have 2 units here and we have 3 antibodies here. So that for capital K it is 90%, so it is 0.9. So WA it is 35%, it is 0.35, and KIT B it is 30%, 0.30. So the number of units required to screen to find 2 compatible units in this patient would have been 21 units. So if there's an ABO incompatibility involved, so if you want the same ABO specific units, then you have to add the ABO prevalence like frequencies in the denominator. So say for a discussion sake, continuing the discussion sake, so can you view my screen?
So the sharing got some, like you have to reshare.
Is that fine now?
Yes, sir.
So now the patient requires exchange transfusion. So the newborn weight is 3 kilograms. The hematocrit of the newborn was 35%, and the expected hematocrit in the product bag is 50%, and the target is 2 TBVs using a CPDA unit, which is commonly used for exchange transfusion. So the formula for estimating the volume requirements, first we need to determine the volume of RBCs required. So which can be determined by volume of whole blood requested into hematocrit of the whole blood requested unit divided by hematocrit of the RBC unit used for reconstitution. So we'll come back to some real examples. So in this case, the first one is the volume of whole blood requested. So we know we are planning a 2 volume exchange transfusion. So with the body weight of 3 kilograms in the newborn, so like for a calculation purpose, newborns we usually take 80 ml or 90 ml per kilogram body weight. So it is 2 times the blood volume. So twice into 3 into 80 ml per kilogram body weight, it comes around 480 ml is the volume of whole blood requested in this patient. And the hematocrit of the CPDA bags are usually around 70%, and the hematocrit of whole blood requested is 50%. So estimating the volume of RBC required, it is 480 ml, that is the volume of whole blood requested, into 50% is the hematocrit of the whole blood requested, and 70% is the CPDA bag which you have chosen, the hematocrit of the CPDA bags. So the volume of RBC can be calculated as 342 ml. So now we need to reconstitute the blood into reconstituted whole blood. So the volume of plasma in this, most of the cases it will be AB plasma. So the AB plasma required will be among the 480 ml, we have to subtract the RBC requirement, like that is 342 ml, that is 138 ml. So this way we could estimate the volume of RBC as well as plasma for reconstituting blood for exchange transfusion. So that is about the antenatal case and the calculations involved. So we'll discuss few about points about the apheresis. So volume estimation in apheresis. So a 50-year-old woman with a history of acute myeloid leukemia, so has a elevated WBC count of 280,000 and 80% are blast. So the plan was to perform a leukocytopheresis, and the patient's weight was 50 kilograms. The height is 150 centimeter, and the hematocrit of the patient is 30%. So which method is used by apheresis equipment to estimate the blood volume? So we all know there are various methods for estimating the blood volume, and we need to choose which method the apheresis equipment adopts. The next question is estimate the blood volume plasma volume and red cell volume in this patient, and what will be the target blood volume to be processed for performing a leukocytopheresis in this patient. So the volume estimation of an individual can be performed by like patient's demographics such as body mass index, age, gender, and height. The commonly used formula is adults, we use 70 ml per kilogram body weight, and for neonates, it is 80 ml per kilogram body weight. So in this formula, we use only one demographic factor, that is weight. So, and as well as age, sorry, not one, two factors, weight as well as age. So the apheresis equipment adopts three demographic factors such as gender, height, and weight. So the formula used are Nadler's equation, which are different for males as well as females. So this is the formula for Nadler's equation for males and females. Using so next, by this formula, we will be able to estimate the total blood volume. So the other formulas in the apheresis commonly used are plasma volume. So plasma volume is 1 minus hematocrit. We know the hematocrit of the patient and we need to subtract the hematocrit from the 1. So for in this case, it is 0.3, means it is 1 minus 0.3 into the total blood volume. So that will give us the plasma volume. If you want the red cell volume as such, you can directly multiply the hematocrit in like in percentage, like in decimal, into the total blood volume. So in this case, it is 0.3 is the hematocrit into total blood volume. That will give us the red cell volume. Extracorporeal volume is usually provided by the kit like by the kit manufacturer. It varies between the companies as well as between the procedures. So extracorporeal volume percentage is estimated as, so extracorporeal volume, which is given by the manufacturer, divided by the total blood volume of the patient into 100. That gives the percentage of the extracorporeal volume for the procedure. Then the extracorporeal red cell volume as a percentage of total red cell volume. The extracorporeal red cell volume is the volume of RBCs within the extracorporeal volume in simple terms. So if extracorporeal volume for a procedure is 150 ml, and what is the amount of RBCs which are in the 150 ml tubing sets? So that is extracorporeal red cell volume. So extracorporeal red cell volume is also provided by the kit, like manufacturer of the company. It varies for the tubing set as I mentioned earlier. So we estimate extracorporeal red cell volume percentage with respect to total red cell volume. So it is ERCV by red cell volume into 100. That gives the percentage of the ERCV. Then the intra-procedure hematocrit. That is the patient's initial red cell volume, which we know how to calculate. Then the ERCV's percentage, ERCV by total blood volume, sorry, ERCV by total blood volume into 100. That gives the intra-procedure hematocrit. That is during procedure, what can be the expected hematocrit drop in the patient. So coming to this example, so the patient weight was 50 kilograms, the height is 150 centimeter, and the hematocrit is 30%, and the gender is female. So using Nadler's formula, the total blood volume of the patient is 3 liters. So now we can estimate the plasma volume easily. So the plasma volume, as I mentioned, it is 1 minus hematocrit into total blood volume, that is 2.1 liters. And the red cell volume is directly multiplying the hematocrit into the total blood volume, that is 0.3 into 3 is the total blood volume, that gives us the 0.9 liters. So answering the other questions, for leukocytopheresis, the recommended volume of whole blood that requires to be processed is 1.5 to 2 times the blood volume. So in this case, the whole blood to be processed is 4.5 to 6 liters based on the patient's body weight. Similarly, what is the amount of target blood volume to be processed for the other therapeutic procedures? So in therapeutic plasma exchange, our target is usually 1 to 1.5 total plasma volume. Similarly, for red cell exchange, it is 1 to 2.5 times the red cell volume. If someone wants to do a therapeutic platelet pheresis, which is usually done for essential thrombocytosis, it is 1.5 to 2 TBVs. So these are the target endpoints for various therapeutic procedures. So if there's a pediatric patient there's a 3-year-old male child who wants to be a stem cell donor for his sibling. The child weighs 15 kgs and the hematocrit of the child is 30%. So for a stem cell collection, we commonly use a continuous mononuclear cell collection kit using spectra optia. The spectra optia has the extracorporeal volume of 300 ml and the extracorporeal red cell volume is 114 ml. So we are asked to comment on the needs of priming the apheresis kit for uh, for this patient. Similarly, the extracorporeal volume and the ERCV volume for the other kits varies. So, for example, if you want to do an exchange procedure, the extracorporeal volume for spectra optia is 170 ml and the ERCV volume is 68 ml. So, why we need a red cell priming is to support adequate oxygen delivery to tissues that may be warranted in a hemodynamically stable patient with a normal hematocrit in an exchange procedure or in any therapeutic procedure when the patient's body weight is less than 50 kgs. For an exchange procedure, we prefer a red cell priming when the body weight is less than 15 kilograms or total blood volume of less than 1000 ml. Or in a peripheral blood stem cell collection, we perform red cell priming when the body weight is less than 25 kilogram or total blood volume of less than 1700 ml. So for exchange procedure, I had mentioned the extracorporeal volume is 170 ml. So that is why we require red cell priming only in patients who are weighing less than 15 kilograms. Whereas a hematopoietic stem cell collection, the extracorporeal volume is 300 ml. So we need to start priming the kit with the RBC when the patient's body weight is less than 25 kilograms. So coming back to this patient, so what is the threshold? So the extracorporeal volume as well as the ERCV percentage should not exceed 15% of the total blood volume and red cell volume respectively. So if the ECV, that is extracorporeal volume, and ERCV exceeds 15%, then the priming of apheresis devices should be considered. So coming to this patient, that donor, the donor's weight is 15 kilograms and the hematocrit is 30%. And we know the equipment's extracorporeal volume is 300 ml and the ERCV is 114 ml. The estimated total blood volume in this child is 1050 ml. So the red cell volume in the child will be 30%, that is hematocrit into the total blood volume, that is 315 ml. So the maximum tolerable extracorporeal volume for is 15%. That comes around 157 ml. And the maximum tolerable red cell volume is 15%. That comes around 47 ml. Whereas the device has extracorporeal volume of more than 300 ml, which is more than the maximum tolerable limit for this child, as well as the device extra ERCV volume is 114 ml, which is beyond the tolerable limit for this child. So hence RBC priming is required in this patient. So I will skip that slide. So the previous slide, it tells about the how to choose a RBC unit used for priming. So the volume of donor RBCs for the priming the kit is 114 ml. That is the ERCV. And the bag which we choose normally is a Sagam bag. So the hematocrit will be 60%. So the volume of donor RBCs required for priming is around 190 ml. That is the RBC volume required in the extracorporeal circuit. And the required volume of the reconstituted blood for RBC priming is the ERCV, that is 114 ml with respect, and it's divided by the preferably the patient's hematocrit. We do not want to infuse a RBC fluid which is having a higher hematocrit than the patient's hematocrit. In this patient, the child who is a donor, the hematocrit was 30%. So we use the same 30%. So the total required amount of reconstituted blood will be 380 ml. So of which we need 190 ml is the RBC unit, RBC from the RBC bag, and the rest can be from the plasma bag. So this is how we reconstitute the blood for priming before a stem cell collection. So we'll go on to the next topic, that is quality control of blood components, which is one of the commonly asked topic. So when we want to estimate a volume from a gram, so we basically divide the grams by specific gravity. Similarly, when we have ml in ml and you want to estimate the grams, so we multiply the specific gravity. The specific gravity of each component varies. For a whole blood, we preferably take around 1.053, and for an RBC unit, we take somewhere around 1.09 or 1.1. For a plasma unit, we take 1.026, and for a platelet unit, we take around 1.04. So now we are asked to estimate a volume of a plasma bag. So the volume of a bag, we have a bag weighing 500 grams. What is the volume of the bag? So we know the grams is mentioned, so we need the volume. So grams divided by specific gravity of the plasma, that is 1.026, gives the volume of plasma bag in ml. The vice versa, if you have the volume and if you want to estimate the gram, so we multiply the specific gravity. In this case, the 500 ml plasma will have a 513 grams weight. So the other common thing which we is asked is RBC contamination in a RDP or an SDP unit. So if like the given RDP unit has a volume of 60 ml with a hematocrit of 1.4 percentage, and the RBC count is 0.2 into 10 power 6 cells per microliter, and the MCV is 70 FL per milliliter. So we know that acceptable RBC contamination limit for an RDP is 0.5 ml, and for SDP it is 2 ml. So the RBC content can be estimated by RBC count, which is expressed in 10 power 6, into MCV, which is expressed in milliliters, that is 10 power minus 12, into volume of the bag divided by a correction factor to convert the like 1000 to make uniformly ml. So 0.20 into 10 power 6, that is then 70 is the MCV into milliliters, that is 10 power minus 12, into bag volume 60 divided by 1000. So that comes around 0.84 ml is the RBC content in the bag. The other method to estimate RBC contamination is by hematocrit. The hematocrit is mentioned here. So hematocrit percentage into volume of the RBC, volume of the product. So we know hematocrit is for 100 ml. So for we have a 1.4 percentage, that is for 1.4 ml in 100 ml. So we want to know what is the RBC content in 60 ml. So 1.4 divided by 100 into 60 will give us the RBC content in the product. These are the two methods where we can estimate the RBC content in the any product. So we can do a QC of a stem cell product in the next case. The volume of the peripheral based stem cell product is 200 ml, and the recipient's body weight is 50 kilograms, and the bag count, the product count is 328,000 cells per microliter. The CD34 count can be expressed in two methods. One, they can directly give you the CD34 value, that is 3720 per microliter. The values as can be given, or they can be expressed in percentage. Sorry. So CD34 count, when the question comes, it can be directly given, the values can be directly given, or they can give a percentage of the CD34 count. So the percentage in this case is 1.03, and the mononuclear cell percentage is 70%, 75%. So we are asked to estimate the whether the dose of the patient, dose for the patient, as well as the mononuclear cell dose of the patient. So the CD34 count, so they can be estimated by two different methods. One, by a single platform using a flow cytometer, where we directly get the absolute CD34 count. So in this case, it is 3720 cells per microliter. If you get an absolute count, you can directly substitute the absolute count value 3720 into the dilution, that is, it is given in microliter, so we have to convert them into ml. So 10 power 3 into the bag volume, that is 200 ml, divided by patient's body weight, in this case 50. So the dose for CD34 is 14.8 into 10 power 6. CD34 dose are usually expressed in 10 power 6. So we usually call them as 14.8 million cells per kilogram body weight. If CD34 count is given as percentage, that is 1.09 percentage, so the CD34 dose can be estimated as the bag WBC count into CD34 percentage. That will give the absolute CD34 count. So in this case, the bag WBC count is 3,28,600 into percentage of CD34 count, that is 1.09 into bag volume divided by body weight of the recipient, that is 50 kg. It comes around 14.3 into 10 per 6 per kilogram. So there will be usually differences when we use a single platform or dual platform for estimating CD34 dose, because in single platform both the WBC count as well as the percentage are obtained from the flow cytometer, whereas in dual platform we get the CD34 percentage from the flow cytometer, whereas bad WBCs are obtained from a cell counter, hematology cell analyzer. So we have two different equipments here, so that is why, so usually we have a minor differences when we estimate the CD34 dose. So now to estimate the mononuclear cell dose, MNC dose, the formula is the bag WBC count into mononuclear cell percentage into bag volume divided by recipient's body weight. So the mononuclear cell percentage in this product was 75%. So the dose mononuclear cell dose will turn out to be 9.8 into 10 power 8 cells per kilogram body weight of the recipient. So mononuclear cells are usually expressed in 10 power 8 cells per kilogram body weight. So coming to the next question. So what processing procedure should be performed on a bone marrow product before issuing for a patient? The weight of the patient is 80 kg and the patient's blood group is A positive and the patient is receiving a marrow from a group AB positive donor. The volume of the marrow product was 1000 ml and the hematocrit of the marrow product was 36%. The CD34 dose was optimal, like 2.8 million cells per micro, I'm sorry, it is kilogram body weight of the recipient. So the recipient is A positive and the donor is AB positive. So it is a case of major ABO incompatible where the recipient has antibodies against the donor red cells. So we need to estimate the RBC content in the stem cell product. So the safer threshold for RBC transfusion along with the any product is 0.4 ml per kilogram body weight of the recipient or approximately 20 to 30 ml of RBCs in the product. So in this case, the RBC content in the bone marrow aspiration product was 36% hematocrit into 1000 ml as the product volume divided by 100, that comes around 360 ml of the RBC content. That roughly comes around 4.5 ml per kilogram body weight of the recipient. So the question here is, what processing procedure will be performed in this patient? The answer is RBC reduction, that is red cell reduction, using either colloids like hydroxyethyl starch can be used for before infusing directly to the patient. So coming back to apheresis, so we have it's another scenario. So patient is planned for an autologous stem cell transplantation. The patient's body weight is 60 kilograms. The recipient, patient's hematocrit is 36%. The peripheral blood CD34 count before collection was 50 cells per microliter, which we require minimum of 20 cells per microliter for initiating apheresis. So in this case, it is 50 cells. So the mobilization was adequate. The collection efficiency of the apheresis procedure for that particular equipment was 55%. Our goal is to collect 5 body as desired CD34 cell dose. So sorry. The formula is desired CD34 cell dose into body weight of the recipient divided by collection efficiency into peripheral blood count of the donor. So in this case, the blood volume to process will be 5 million cells per kilogram body weight is our target, that is 5. The body weight is 60 divided by collection efficiency, it is in percentage, so it is 0.55 and the peripheral blood CD34 count is 50 cells. So the blood volume to process is 10.9 liters of unanticoagulated blood. So this is the unanticoagulated blood. We can estimate using this formula. So we know the ACD ratio. The ACD ratio is 1:12. So the AC volume used for processing this blood would have been 10.9 liters divided by 12. That comes around 910 ml. That is 0.191 liters. So the total blood volume required to be processed for this patient would have been 10.9 plus 0.91 liters of blood. That is 11.81 liters of whole blood is required to determine to approximately get a 5 million target cells, CD34 cells per kg body weight for this patient. So this is only an estimate. So, but in real time, so this calculation may have some plus or minus changes. Similarly, we can also estimate the product yield which we can obtain with the patient's characteristics. So the patient weight, all we know. So we have the how much amount are available in the 34 in year count.
Sir, audio, there is some issue.
CD34 cells. Per kilogram body weight. The collection efficiency is the percentage of cells that is collected from total number of cells processed. So I'm extremely sorry, I have some network issues here. The formula for collection efficiency is the percentage of cells that is collected by the total number of cells processed. So the collection efficiency, they like the one. So into WBC count of the product into volume of the product divided by peripheral blood CD34 into total blood. Formula appears to be little complex. The formula can be simplified in the next one, the collection efficiency. The collection efficiency is the product, what is the CD34 cells available in the product divided by peripheral blood CD34 count into volume processed. So this formula uses only peripheral blood CD34 count before collection. So to improvise the formula, so they came up with the efficient peripheral blood CD34 count before procedure. The CE2 formula, we take a peripheral blood CD34 count before the procedure as well as after the procedure and take the average. That value can be added here and multiplied by the product we got somewhere around per kg body weight. We need to subtract the ACD volume and then enter the blood volume to be processed for estimating the collection efficiencies or any other formulas. So the collection efficiency is around 55% for an apheresis stem cell collection, which is a very good efficiency. So coming to the next one, request allogenic transplantation. The child has 3 full siblings who are willing to be a stem cell donor. What is the probability of identifying a HLA identical sibling for this patient? So the chance of having two siblings with an identical HLA is 1 in 4, that is 25%. And the chance of probability of not having two siblings that do not have a similar HLA typing is 75%. So the formula for estimating the probability of finding an identical sibling is 1 minus 0.75 to the power n. N stands for the number of siblings. So in this child, it is 1 minus 0.75 to the power 3. It comes around 0.578. That is, there is 58% chance of identifying a sibling for this child. Then we can discuss few about gene frequency. This is also commonly asked. So in this scenario, this case scenario, there is approximately 6,129 donors who are typed for capital M antigen, and they observed that the M positive among the people are 4826 individuals and M negative individuals are 1303. What are the gene frequencies for M and N allele? The second question is, how many people in the population are heterozygous for MN? So to understand that, we need to go back to the Hardy-Weinberg's equation. P plus Q is equal to 1. So P stands for the gene frequency of the dominant allele. In this scenario, we use M and M allele as a dominant allele, and Q is the gene frequency for the recessive allele. So for us, it is N is the recessive allele. So the Hardy-Weinberg's is P square plus 2PQ plus Q square is equal to 1. So using this formula, so we know that the number of people who are M positive is 4826 individuals. So P square plus 2PQ are the people who are having M antigen positive. So they are 4826 people divided by total number of individuals, that is 6129. It comes around 78.4%. So with this, we can identify Q square as 1 minus P, like the rest of the individual, that is 1303 divided by 6129, that is 21% or 0.21. So the Q can be determined as square root of 0.21, that is 46%. With Q, we will be able to identify P. The P turned out to be 0.54. So the gene prevalence for gene frequency for M allele is 0.54 and the N allele is 0.46. Coming back to the question, what is the prevalence of it in the heterozygous state? So to identify the heterozygous state, we need So we need 2PQ, that is 2 times the M allele as well as the N alleles frequency. So in this case scenario, the heterozygous frequency will be 0.50%. So these are few administrative questions. A department has one apheresis equipment for platelet donation, and the department wants to purchase an additional apheresis equipment for SDP. An average daily SDP collection in the department is 3 units, and the procedure time per SDP is approximately 1.5 hours. And the blood center operation time for apheresis is 9 a.m. to 3 p.m. on an average 6 hours. So you are asked to perform a need assessment of an additional apheresis for your blood center. The formula is number of hours an equipment used per day divided by maximum number of hours the equipment can be used into 100. So in this case, so if the percentage appears to be less than 50, then it is a not economically viable for a department to proceed with a new purchase. So we have 3 procedures and an average. So we have 4.5 hours as the equipment time, operating time, and the maximum operating time possible working time is 6 hours is for apheresis. So it comes around 75%. So this is how we can approximately assess the need assessment for additional equipments for in some medical institutions. The next question is critical or reorder levels of consumables for your blood center. So you are given in charge of an inventory management of your blood center, and the present inventory of antiserals are 30 vials, like 30 sets of vials. So one set is like 1 vial of anti-A, anti-B, anti-D1 and D2. Your average consumption per day is 2 vials, and the average time for delivery of your purchase order is 7 days. That is, once the purchase order is released, 7 days you get your next lot of reagents. And the buffer stock, as per your department SOP, is usually 14 days inventory has to be maintained. So you are asked to decide whether you need an anti-sera based on your present inventory. So reorder denotes the stock level at which fresh order can be placed. So the formula is consumption of items per day into lead time plus buffer stock. So the lead time is the time for the delivery of supply. So lead time is the average duration of time in days between placing an order and receiving the supply. And buffer stock is the quantity of material which are set aside as a safeguard against variation in demand as well as procurement. So using these variables, so in our case, our daily consumption is 2 vials and a lead time is 7 days for delivery, and our buffer stock is for 14 days, that is 14 into 2, so it is 42 vials, and our present inventory is 30 vials, so it is better to place an order for our next set of consumables. So the next formula is calculation is a case scenario on thalassemia patient. The weight is 40 kg. The hematocrit of the RBC unit available is 60%. I'm extremely sorry about the technical issues. So coming back to this patient, the hematocrit of the RBC unit which we give for thalassemia is 60%, and the target rise in hemoglobin is 3 grams per deciliter. So and on average annual transfusions, there are approximately 13 transfusion happens per year. It is not 13 units, it is 13 transfusions for this patient annually happens. So estimate the annual RBC for this patient. So the blood record expected increment in hemoglobin, that is desired minus actual hemoglobin, into weight of the patient into transfusion factor. Transfusion factor was calculated by dividing the ml like volume of blood transfused by increment achieved in an individual patient. So they estimated as from a study which is cited in the below transfusion journal, the transfusion factor is 3 per hematocrit of the RBC unit which is given. So the formula is fine-tuned as volume of RBC required is equal to weight in kilograms into hemoglobin increment required desired into 3 divided by hematocrit of the unit selected. So in this child, so the volume required will be 3 into 40. So 3 is the expected rise in hemoglobin into recipient's body weight, that is 40 kilograms. So 40 kilogram is the weight of the recipient. 3 into 40 into transfusion factor, that is 3 divided by hematocrit of the unit is 0.6. So it is 600 ml per transfusion. So the annual transfusion requirement is, we have 13 events of annual transfusion. So 13 into 600 ml divided by the recipient body weight, that is 195 ml per kilogram per year. The same example, we need to raise a hemoglobin by 3 grams in a patient weighing 60%, and the expected hemoglobin rise is 30 grams per deciliter. So we need to use a formula 15 ml per kilogram body weight. The recipient weight is 40 kilograms. So 15 ml per kilogram into 40 is 600 ml of blood needs to be transfused for each event to get a 3 grams increment in hemoglobin. This is the reference where I took this table from. So next, coming to the factor replacement dosage, that's a hemophilia A patient weighing 60 kilograms with a hematocrit of 45%, and the present factor level is 20%, and the child is planned for and the patient is planned for neurosurgery. Advice on the initial and the maintenance dose for this patient. The for initial dose estimation for hemophilia, For hemophilia A, there are two methods. The first method is the plasma volume method. So you estimate the plasma volume of the patient and multiply it by the desired hematocrit, like a desired factor level increment. That is the factor
So the
8
slide
target
hasn't changed.
minus initial factor levels.
Now it's okay, sir.
Now it is okay. So this is one of the method to estimate initial dose estimation for factor 8. So we can also use a thumb rule. In thumb rule, 1 unit of factor, recombinant factor, increases factor 8 levels by 2%. So we can use weight into factor 8 target minus factor 8 baseline divided by 2%. Like 1 unit raises by 2%. So we are dividing the value by 2. So thumb rule is usually used for recombinant factors assess. These are the two methods for estimating hemophilia A factor estimation. Similarly, for hemophilia B, the equation is multiplied by 2 because the factor 9 has both intravascular as well as extravascular tissue like distribution. So we need to give twice the volume of factors to attain the target factor levels. So it is 2 times the blood volume, plasma volume into factor 9 target minus factor 9 initial. And for the thumb rule, 1 unit of factor 9, recombinant factor 9 increases factor levels by 1%. So it is weight into factor 9 target minus factor 9 initial levels. So this is about the initial dose, and for maintenance dose, half of the initial dose is given as maintenance dose. For factor 8 deficiency, the maintenance dose is given at 8 to 12 hours frequency, and factor 9 deficiency, it is given at 8 into 24 hours because it has a much longer half-life than factor 8. So using this for our patient scenario, the patient's blood volume is estimated as 4,200 ml, and the plasma volume, using plasma volume method, the plasma volume is 2,310 ml. So for neurosurgery, we expect our target levels to be 100% before surgery. So the initial dose of factor 8 using plasma volume method is a plasma volume into 100 minus 20%. That is 1,848 international units. And maintenance dose is half the initial dose, which is 924 international units, can be given 8 to 12 hourly interval. And when you use a recombinant factors, the thumb rule, when you use a thumb rule as a formula, so we multiply directly by the recipient's weight, that is 60, into the expected increment in factor levels, that is 80%, divided by 2, because 1 unit raises by 2% of factor levels in the recipient. So it comes around 2,400 international units. And the maintenance dose for factor 8 is half the initial dose, that is 1,200 international units every 8 to 12 hourly. Similarly, for factor 9, so we could identify the initial dose is twice the actual dose which we calculated for factor 8, that is 3,696 international units, and the maintenance dose is half the initial dose, that is 1,848 international units every 18 to 24 hourly. Using thumb rule, 8 into expected increment in factor levels, that comes around 4,800 international units, and the maintenance dose is half the initial dose, that is 2,400 international units every 18 to 24 hours. So like World Hemophilia Federation adopts using factor estimation using thumb rule. The problem with thumb rule is it generally overestimates when compared to the plasma volume method for estimating the factor levels. The other dosage commonly asked is fibrinogen. So the same patient, the weight is 60 kilograms, the hematocrit is 45%. The patient's initial fibrinogen levels are 75 milligram per deciliter, and the target fibrinogen is 150 milligram per deciliter. And on average, one bag of cryo has 250 milligram fibrinogen. So to estimate the amount of cryoprecipitate required, so we can estimate the plasma volume from the blood volume into expected increment in fibrinogen levels divided by the average like bags fibrinogen content, that is 250. Also, because the fibrinogens are expressed in deciliter, we have to convert them in ml, so we divide by 100. So in this case, the blood volume will be 70 into 60, and the plasma volume can be determined by 1 minus hematocrit, that is 0.45. And the expected fibrinogen recovery like increment is 150 minus 75 divided by 100 into 250. So roughly around 7 bags of cryo will be required to increase the fibrinogen levels up to 150 milligrams per deciliter in this patient. So you're planning an autologous donation and the patient's weight is 25 kilograms, but the blood bag available with the blood center is 450 ml. So determine the volume of anticoagulant to be removed from the blood bag for ensuring adequate anticoagulation. The volume to determine the amount of anticoagulant removed, first we need to estimate the volume of anticoagulant required. So we know for every 100 ml, we require 14 ml of anticoagulant. So using this formula, so the anticoagulant removed can be determined. So in this case, the volume of blood to be removed, the maximum tolerable limit for an individual is 10.5 ml per kilogram body weight. The patient's body weight is 25 kilograms, so it is coming around 262 ml. So anticoagulant required will be 14 ml, like 14 into 262 by 100, that is 37 ml is required for this child to collect 262 ml, and the amount of anticoagulant to be removed is 63 ml is available in the bag. So we require only 37. So 26 ml of excess anticoagulant can be removed from the bag before initiating a collection for this child. The next example is percentage hemolysis to estimate the percentage hemolysis. So you are asked to you are given a QCM to estimate hemolysis. The supernatant hemoglobin levels using plasma hemoglobinometer is 200 milligrams per deciliter, and the hematocrit of the bag is 56%, and the total hemoglobin content in the bag is 18.2 grams per deciliter. So what is the hemolysis in the unit RBC unit? We know the acceptable limit for RBC hemolysis in the unit is should be less than 1%. So the percentage hemolysis can be calculated as 100 minus hematocrit of the bag into supernatant hemoglobin from the plasma hemoglobinometer divided by total hemoglobin available in the bag. So it is 100 minus 56% into 200 milligram is the deciliter is the available value from the low plasma hemoglobin divided by the total hemoglobin available in the bag. It comes around 0.5%. So the bag is acceptable within the acceptable limit of hemolysis. So coming to WBC reduction, that is logarithmic reduction from a following glucodepletion. So the volume we have given a pre-count as well as post-count. The volume of the bag RBC bag pre-count is 310 ml and the hematocrit is 63%. And the post-count it is 275 ml and the hematocrit is 56%. The pre-count WBC is 0.3 into 10 power 9. So you are asked to estimate the residual WBC count in the bag, so which we estimated as 0.8 into 10 power 6. So we know how to estimate a residual WBC count using a Nagard's chamber. So we could count the Nagard's chamber. The counts, the formula is leukocytes per microliter is cells counted. So the leukocytes, residual leukocytes in the bag is estimated as cells counted into dilution divided by total volume of area counted. So in our scenario, so we have 30 cells in the Nagard's chamber and we have a total area is 50 microliter and the dilution we use is 5. So it comes around 3 cells per microliter. So the dilution 5 is because we add a lysis reagent as well as Turk's fluid in case of RBC unit. In case of platelet unit where there is no need of lysis, we add 5 as a dilution factor and the entire 5 will be from the Turk's fluid. So 3 cells per microliter was the residual or WBCs available in the bag. So estimating the bag's WBC content, it is bag's WBC count per microliter. Converting them into ml
Sir,
is
your
1000.
slides are not visible. No.
Now it is okay.
Not yet.
So the bag, like I will just now it is okay. Graphic?
It hasn't come, sir. Can you just share once more? Try once more. Yeah, now it's okay.
Okay. So the bags WBC can be estimated as WBC count per microliter into the bag volume. So the bag volume is 275 ml. So we have 3 cells per microliter with a conversion factor of 10 power 3 for ml. It is 0.8 into 10 power 6 is the residual WBC count in the bag. So to estimate the logarithmic reduction, so the logarithmic reduction formula is logarithmic pre-count divided by post-count. So in our case, our pre-count is 0.3 into 10 power 9 and our post leukodepletion is 0.8 into 10 power 6. So it can be roughly log 10 power 9 by 10 power 6, which can be written as 9 log 10 minus 6 log 10. So it can be combined as 9 minus like logarithmic of 10 with 9 minus 6, that is 3 log reduction. So the percentage of logarithmic like WBC reduction can be estimated by pre WBC count minus post WBC count divided by pre WBC count into 100. So in our scenario, it is 0.9 into 10, 0.3 into 10 power 9 minus 0.8 into 10 power 6 divided by 0.3 into 10 power 9 into 100. The value comes around 99.7% reduction in WBC following leukodepletion. Similarly, we can also use a flow cytometer for estimating WBC count, residual WBC count. When you use a flow cytometer, the formula we need these parameters, that is the number of WBC events acquired divided by like number of WBC events. We need the bead events which is acquired and the amount of bead which are added into the tube and the volume which we use. So when we have these variables, the formula is total beads into total leukocyte events, WBC events, divided by total beads acquired into the sample volume. So if you can see the values, so 48,350 is the amount of beads which are added. The bead the volume is 100 microliter, comes out 2.6 by liter. So estimate WC count in when we are having 50 ml 10 are estimated by sample OD value. We prefer a E ratio of 1.5 to 2 for an indirect ELISA, and for sandwich ELISAs, we prefer a E ratio of 0.7 to 1.0. So to estimate me in a by number, then we need to estimate, then we need to square the x minus x bar to come to compensate for negative and positive values. X bar deviation by one standard mean plus or minus one standard deviation or 3 standard deviation. Then we also are commonly encounter with the ratios used for pre-transfusion testing. The commonly used ones are CT ratio, that is number of units cross-matched by number of units transfused. If a value is less than 2, then the cross-match is considered ideal. If the CT ratio is more than 2, then it is better to go for type 1 screen for such surgical procedures. The next formula is transfusion probability, that is number of patients transfused by number of patients cross-matched for the particular surgical procedure into 100. So if the value is more than 5%, it is considered ideal for doing a cross match for this particular surgical procedure. If the value is less than 5, then there is no need for cross matching for a particular surgical procedure. Then we have a transfusion index, which is number of units transfused by number of patients cross match. If the value is less than 0.3, it signifies there is no need for cross matching for the particular surgery. Then we also have a MEETS criterion, which is used for estimating the maximum surgical blood ordering schedule. It is usually so the MEETS ratio the MEETS criterion is used for MSBOS. It is 1.5 times the transfusion index for a particular surgical procedure. So then we are also commonly asked about the plate count increment. So count and the platelet recovery. So we have an example here. The patient's weight is 15,000. So the corrected count increment for the patient is, I'm extremely sorry. So the corrected count increment is expected increment in microliter into body surface area by number of transfused in terms of 10 power 11 into 3,600. So in this case, it is 23,000 minus 15,000 into body surface area is 1.5 divided by number of platelet transfused is 3. So the CCA is 4,000. And the percentage platelet recovery can also be estimated by like platelet increment into blood volume divided by platelet dose in 10 power 9. So platelet increment is given in liters, that is 23 minus 15 into blood volume in liters. Blood volume should be expressed in liters and platelet dose in 10 power 9. So the percentage recovery can be obtained. So there are other commonly asked questions. What are the quality indicators for blood bank? So the percentage of TTI positivity, that is the combined positive cases of HIV, hepatitis B, hepatitis C, syphilis and malaria by total donors for the particular month into 100. Adverse transfusion reaction rate is number of donors with adverse reaction and adverse transfusion reaction rate is number of transfusion reactions in the particular month divided by number of blood components transfused into 100. And the blood wastage rate is number of components discarded by number of blood components issued into 100. The turnaround time, it is usually the time available for time taken to calculate from the time the request is received in the blood bank till the time blood is cross-matched are kept available for the patient. So turnaround time can be calculated for routine cases separately and emergency cases separately. The adverse donor reaction rate is number of donors with adverse donor reaction with the total number of donors into 100. And the component QC failures for the each month is number of component QC failed by total number of QC tested in the particular month into 100. The deferral rate is donor deferral rate is number of donors deferred by total number of donors donated as well as total number of donors deferred into 100. Components is total components issued by total whole blood as well as component issued into 100. For TTI outliers, so we consider number of samples deviations beyond 2 standard deviations into 100 is percentage of TTI outliers. So total number of batch assays is delay like total delays in transition beyond 30 minutes after issue minus sample audit by blood bank every month is the number of delays in the particular month. And there are few must know formulas for a exam going postgraduates. So in general, we need to know the dilution of percentage solutions. For example, you should know how to prepare a 5% albumin from a 20% albumin, which is commonly used for a plasma exchange. We need to know about the molarity, normality, and centrifugal force formula. And we need to know about the genetics Hardy-Weinberg's equilibrium, which we discussed, and probability of parentage percentage. So we need to know about the blood donation, about anticoagulant required, and maximum then with respect to TTI, about incidence and prevalence of TTI, residual risk or window period risk, then dose calculations for various coagulation factors as well as cryoprecipitate, inventory managements like cross-match and transfusion ratio, which we discussed, platelet increment and platelet recovery, the blood volume requirements in the apheresis procedure, then fetal-metal hemorrhage, RH immunoglobulin are intra transfusion in obstetrics. In pediatrics, in case of exchange transfusion and transplantation, about CD34 estimation, mononuclear cell estimation, coagulability count, and QC of all the blood products, and quality indicators, which we discussed briefly here, and estimation of RBC count by a conventional methods. So these are things we should understand, like we should be familiar before appearing for a postgraduate exam. So this presentation was possible only with the help of my friends. I would like to acknowledge Dr. Anju R. Kuru, my colleague at my center, and Dr. Channa Deepika from KMC Manipal. So Dr. Angel Mary Sam from Sri Chitra Tirunal Trivandrum, Dr. Veena Shanai, Dr. Linda, and Dr. Arif from Amrita Institute of Medical Science, Kochi. So I would also like to thank the authors of this book, because most of my cases are from this textbook, and I will be happy to answer any questions if available. Thank you. I thank the organizers for the opportunity, and I am extremely thankful for all the patient listeners who could bear with my technical issues as well as my lecture. Thank you.
Thank you, sir. When we thought about conducting this calculations in transfusion medicine, we never thought it would be like we went back to our mathematics days. So thank you, sir, for making all those things simple. I think some people had issues in accessing the this thing. Like it was a holiday also today. When we planned for the CME, it wasn't a holiday, but we'll anyway be uploading the video in YouTube. And if anybody has any queries, you can ask sir. I'll undo the force mute. So if anybody wants to ask sir, you can unmute yourself and go ahead. So there were some queries in the chat box. Did you get any personally?
One second. There are a lot of messages. I'm just giving one second.
Or you can raise your hand. I'll unmute them.
So one of the question is percentage of TTI outlier. How do we calculate number of batch assays in CLIA equipment?
Yes, sir.
So the number of batch assays is like in CLIA one like, though it is because it is a random access equipment, that might be the reason you might be posting this question. So we can consider 24 hours number of samples processed in 24 hours as a single batch, and then we can estimate the percentage of TTI outlier to estimate this formula. Then so sandwich ELISA 0.7 less than 1. So won't our spy will be, sorry, spy will become negative? I didn't get a question. Sanim Anjum Saik. Can you, Dr. Sanim? Saneha Anjum Sheikh. So,
Yeah, you can unmute yourself and ask. Saneha Anjum Sheikh.
0.7 less than 1. So won't the like I don't have any personal experience with the sandwich ELISA for calculating like E ratios. So the values were obtained from QMS handbook of NACO. So we generally use third-party control here at our center. So for a so I will get back to you with the answer. Like Dr. Saneha, if you can share your mail ID, I will find the answer and get back to you on that point. And Dr. Varun has asked any methods to calculate approximate yield of PBSC from a mid-procedure CBC. So the company people usually recommends do a product CBC count, and if the value is 3 times the baseline count, like the peripheral blood count, if the value is 3 times the peripheral blood count, then we are going in the right direction. That is what the company's technicians mentioned. Okay. Dr. Revati, you want to ask something?
Yes, sir. Good afternoon, sir. It was a very super presentation. Sir, on your slide, in your slide on quality of blood components, there was a mention of femtoliter, MCV.
Okay.
So it was expressed as 10 raised to minus 12. But, sir, femtoliter is 10 raised to minus 15.
Um, okay.
So this has been a doubt for me for a long time. So,
Revati, this was actually from my presentation, this calculation. Revati, I will get back to you with the answer.
yeah,
There
sure,
are
sir.
other
No
people. There
problem.
are other people who are mentioning as 10 power minus 12.
Okay.
So I
Yeah,
had referred.
we can get back to you, Revati.
Yes, sir. Okay.
Dr. Urvashi, while calculating the blood requirements, when you say the past blood utilization, does it include all the past component issued, or it's just the LDPRBC? So, Dr. Urvashi, you are mentioning about the initial question, the estimating the blood requirement for a center. So here we are saying blood requirement is about the number of whole blood donations required. Urvashi? And Ganesh, thank you. It is femto is 10 power minus 15 and pico is 10 power minus 12. So I'll get back with the formula. So I had referred to another presentation for the formula. I'll find the answers and I'll get back. I'll share with the organizers.
Sure, sir.
And there's another. Revati, you want to ask one more?
No, sir. Thank you, sir.
Balavaskar has asked discard rate denominator.
Discard rate is the total number of components discarded divided by total components issued into 100.
Shaniba? I have put the email ID in case if anybody has this query, you can directly send it to us. So we'll send it to Mohan sir and get back to you. And uh, like whoever has filled the form with their email IDs, in case Mohan sir shares his presentation, we'll share it to that also. Anything else? Okay.
Thank you, sir. It was an excellent session. The certificate link is shared in the chat box. Kindly fill the form so that the certificate will be sent to your email ID. There are no more queries. With this, we come to the end of the session. Thank you all for attending. Have a great evening. Thank you.
Thank you and bye bye.